That was great. I want to thank all the presenters. It's actually after 5, so I'm, it's 5 on the nose. I'm happy to present this case if you want to do this, or we should break. What do you think, Alec?
Let's see if we have any questions.
Yeah, questions from the audience? Oh, some of those, I guess we answered all the questions. Huh?
I have a question for Dr. Farber. So that was a really great presentation on those mixed ulcers, probably the best one I've seen, so thank you. So the question is, how aggressive are you in those patients at looking for proximal venous occlusion, iliofemoral venous occlusion, that can be treated with angioplasty or stenting, or in our practice we do an endovenectomy in the groin and then an AV fistula and then angioplasty and stent the occluded iliac?
That's a great question, because it's very difficult to know when there's venous occlusive disease in the iliac. Duplex works wonderful in the leg, but when you get into the iliac veins and the vena cava, it does not work very well at all. In fact, even venography is not great. CTV, MRV doesn't work great. The best way to evaluate whether or not a stenosis is present is actually IVUS. And of course, that would be an invasive procedure. So we don't have a great way of evaluating these patients, and I think that we are probably doing a disservice to them. I wish there was a more or less invasive way to know whether or not somebody has occlusive disease on the venous side, because I do believe that, and certainly it's been written about, that the frequency of such disease is more common than we believe. Do you have a way, Tim, that you evaluate these patients?
Well, we usually start out with, if we have clinical suspicion based on examination and on the duplex, our imaging experts suggest that MRV is a good way to go to at least get an initial look. And then if it looks like it, we'll just do a regular contrast venogram, and as a pure diagnostic study, not at the time of intervention. And it's not really my area of expertise, but the MRV seems to be a pretty good way to go and seems better than the CT venogram.
Yeah, I think MRI in general is an interesting modality. It really depends on not only the hardware that's used, but also on the radiologist who is creating the various sequences. So there are some places where MRV is wonderful, and there are some places where it's not. So,
it's interesting. So our imaging experts are actually our cardiology colleagues, and so we, as part of the Heart Institute, and so we can, they tailor the exams pretty well. The other thing that's interesting is we had the visiting professor come 4 or 5 months ago and talk about, it was Tony Comarada, talk about these proximal venous issues, and it raised awareness in the wound care center and in our practice, and the cases started coming out of the woodwork. So I think you're right. We underappreciated it for sure, and just awareness of it, I think, is important.
Yeah, I would second that. This is, if you don't look for it, you won't find it. It's like so many other things. It's definitely been the case for pulmonary embolism, for example, and people. It's amazing our basic protocols for looking for in a PECT doesn't go down in the iliac veins. They just do the chest. And how many of your sites do they go down below the chest when they're doing a PECT? Most don't. And where's the clot come from? Do a duplex of the legs to the CTPE, but they miss the iliac veins, and it's a really interesting thing. And it seems to me that with the venous thing, that's a very complex issue that you would definitely want to revascularize the venous outflow first before you do the arterial. Is that what your summation was of that?
Unless the arterial disease is severe. So if the ABI is less than 0.5 or equivalent, you may want to revascularize the arterial disease first, because then you can initiate compression therapy.
So I had a question for my podiatry colleagues who presented these amazing cases. You know, in the era of resource limitation, how do we decide when, you know, when a leg is there a way up front, maybe the Wi-Fi criteria may help us, but how are we going to decide how much effort and energy to put into these limbs that are so far, you know, Rutherford 6 and really at the extreme levels? And, you know, the cost-benefit analysis and so on and so forth. I mean, those are remarkable saves that you showed, and I'm just wondering, you know, but you're extraordinary, and I mean that. What happens in most environments, I imagine, is that patients lose their limb, and whether that's, you know, what's the balance there?
Yeah, I think I can take this first part. I think it's a difficult question to answer, and it kind of parallels Dr. Sullivan's points about, you know, open versus endo. I think it really oftentimes boils down to a case-by-case basis. I don't know that there's anything definitive that can be applied to all patients. Some patients do much better with primary amputation early on. I think the overwhelming goal is to restore functional weight bearing, be it with their own anatomy or with prosthesis.
Yeah, I'd agree with that overall. I think that certainly we're kind of looking at some of these cases as well, because we do appreciate that as you know, as the insurance companies tend to, or are looking to really go to a bundled payment system for managing the wounds, you know, you're kind of limited on what you can do, and so you can't just throw everything that you have at these patients anymore and take them back to the operating room for multiple visits, because you're going to wind up losing a lot of money on. And so I think you have to kind of pick your patients wisely. I certainly lean on, you know, not just only our vascular and interventional people in our hospital systems, but on you know, the dietitians, on the infectious disease people, and you know, I mean, I think that you know, in any of these cases, we're willing to give anything a shot. But I think at some point, and I don't think we've quite gotten there yet to give a clear definition as to who gets the salvage and who doesn't. You know, but I think we're going to have to start looking at those a little more closely, and we're definitely doing that down at Baylor.
So, Tim, as one of the really original surgeons who was very involved in endo. You know, I know you work with Mike Backrack, and you guys are really, you know, stretching. What's your perspective? Maybe we finish up with this. What's your perspective on the relative roles of each of these things over time? I think you have you were president of Viva for 3 years, and you know, of course, that's all about endo. Not all about endo. It's about, you know, endo and surgery. I mean, I think you actually converted us a little bit to sort of the balance. But what would be your sort of perspective over time, how things have gone, and where do you think we'll end up?
That's a really good question, Kenny. I think that you know, back when I trained in Cleveland, there was no endo, and when I came back on staff, Bob Grayer was just starting to do a little of this and a little of that. And as the technology's improved, as the ability to get down and fix the pedal arch has improved, as cardiologists and radiologists and vascular surgeons are now able to do these things, it really doesn't depend on discipline anymore, you know, where you trained. That I actually think that the pendulum has probably swung too far towards the endo. And I actually often berate my younger surgical colleagues when we have case conference every week, because their mindset is endo first, second, third, and fourth, when sometimes there's a pretty easy and durable surgical alternative which in a good risk patient. And so it's that way for CLI, it's that way for aneurysmal disease, it's sometimes for carotid disease. Well, the lesion's a little high, and so we should try and stent it, but the patient's not really high risk. So my hope is that through conferences like this, and where the organizers are good enough to have surgeons represented and have podiatry represented, it's not just cardiologists, that the pendulum will swing back a little bit towards a more reasoned approach to try and fit the technology to the individual patient. And I think that Best CLI is going to give us some actually some data to hang our hat on because there's such a paucity of it.
Thanks. All right. Last word.
Thank you, thank everybody.